Hi, good morning. Thanks very much for inviting me to do this. Initially, I was going to do a bit of a data presentation, but I'm not. After one of the phone calls with the planning committee, I decided to be a little bit more forward-leaning at least. And that means I'm so forward-leaning, I don't have any data on what I'm about to tell you. Instead, I'm going to try to make an argument for doing something in terms of data collections about patient-reported outcomes.
Can everyone hear Arthur okay, or do we need to get closer to the microphone?
It's okay?
Okay.
That's better. I'm sorry. So what I'm going to talk about is how we collect data in the real world about patient and treatment experiences. And in case you need a reminder, self-reports are incredibly important throughout all kinds of science, not only as prose by themselves or as self-reports by themselves, but as they are used in other kinds of data and data gathering things between, say, physiology and genetics. We don't want self-reports to be the weakest link in the chain. So how do we what's the most common way of collecting self-report data? It's generally with questionnaires and interviews that have relatively substantial recall periods over time. That is, we ask people to remember things about their daily experiences over long periods of time, a month, a week, 2 weeks, sometimes a year. And there are lots of problems with doing that. These have been well documented. Here I mention just a few of them, that our memories really aren't up to the task of long recall. And our brains don't allow us to recall things as accurately as we like. There are a set of cognitive heuristics that come into play, such as the peak end effect, that moderate how we actually remember things. We actually may even switch from one type of memory recall to another type of memory recall as we increase the recall length. So there has been, over the last 30 years or so, a lot of development of real-time or near real-time data collection strategies. And that's in order to eliminate the retrospection, but also to get more deeply into patients' lives. There are daily diaries. There's something called the day reconstruction method, which is a fancy kind of diary about yesterday. There's ecological momentary assessment, and there's the experience sampling method. These are all ways that are now being used to collect medical data from individuals. In terms of EMA, which is a particular focus, a particular interest of mine, this is where we go into the real world and we focus on a patient's current state. We randomly sample from them so that when we're trying to generate our estimates of how they're doing, we know that they are unbiased. There are lots of different techniques for doing this. This is just an example of what a person who is in a study like this, what their day might be like. You can see that for day one, they are sampled, in this case, 5 times at random intervals using a smartphone or a dedicated device. But there are lots of variations that have to do with being signaled by events in order to collect data, which we can't go into. Patients usually do this over long periods of time. A week, long is relative, a week, but there are some EMA studies that go up to a month. Often the devices that they use are by necessity very brief, because you're asking a person to do something many times a day. So the assessment may just be 2 or 3 minutes, and therefore the questions are very brief. For example, in the environment, we might ask about who you were with, where you were, what you were doing. We might ask about your affect, your stress, your pain. And then, given the particular kind of study that you're doing, particular symptoms might be asked. Again, all collected on some kind of a device like this. So where am I going with this? What's the issue here? The issue is that there are standards in modern ways of developing questionnaires, self-report assessments, that, as I'll say in a moment, have been ignored in the development of real-time and near real-time data assessment. And these have to do with the qualitative input from patients. What's happened in the past is, in fact, that real-world assessments, diaries, EMA, DRM, have not been held to the same standards that other questionnaires have. I don't know why, but we've gotten a get-out-of-jail-free card in terms of the psychometric police. They've left us alone, but there's no logical reason for this. So, what's my proposal that I've said is sort of forward-leaning at least? The proposal is to switch from artificial testing, from artificial cognitive interviews for these real-time assessments to real-time cognitive interviews. In other words, to develop the questionnaires, these mini questionnaires that we're using, to expand their content base, I think that we need to be doing in-field, real-time cognitive interviews where, for example, we call people up at the intervals that we would normally be beeping them at to collect information, or we call them up in the evening. And what's the advantage? What's the benefit of doing this? Well, I think there's twofold. One is, I think it'll provide us a much richer, deeper understanding of what patients' experience of disease is, in a way that we simply don't have. Bringing someone into a room and then trying to do a cognitive interview about what their momentary life is like is a difficult task. I think it will also produce new hypotheses. I view this also as a hypothesis generation exercise, much like a clinician knows an awful lot about what's going on with their patients because of the particular interaction they have. These qualitative approaches to collecting real-time data, I think, will enhance the whole field of real-time data collection, and hence also the endpoints that are being created from daily diaries and momentary reports in the pharmaceutical industry. Thanks very much.
Wow. Thank you, Arthur. I've never seen 4 speakers actually hit the red button as well as these guys have. So congratulations. Questions for Arthur? Mary. Thank you for dealing with the technology. Hit that button. Turn it towards you a bit.
Turned red.
All right, great. Thank
Mary
you.
Tobin from the Alliance for Clinical Research Excellence and Safety. Cultural anthropologist by training, so I love what you're saying. But my finding has been in a lot of patient reported outcomes and a lot of research, the key problem is the ability to ask good questions, which is frequently totally lost in a lot of these endeavors. How do you go about thinking about training people to do that? Because it's very hard to do.
The proposal that I'm making is that there be dedicated studies, and we actually are expecting funding to be able to do one of these, where we use these qualitative interviews using anthropologists, using sociologists and psychologists to develop a new set of questions that are relevant. I'm not proposing that this person-intensive approach, interviewer-intensive approach, be used in all studies as common fare. What I'm trying to do, much like we do with standardized questionnaires, is say, in the development phase, we need to include something like this. Because the questions, I mean, everyone says, we don't want armchaired questions, and of course that's true, but that's essentially what's been done in the real-time and near real-time data collection field. And I'm trying to advance beyond that.
Excellent. Second or third question, in the back. I'm sorry, I can't read your title.
Hi, it's Ron Bartek, the Friedreich's Ataxia Research Alliance. Got a question for you. A wonderful presentation, by the way. And maybe in a way it's for the other speakers as well. But wondering how these data that you're collecting in a very innovative way are then correlated with other data from maybe exam-based natural history studies, and how are those correlations then used to inform endpoint selection? You know, what's the process?
Well, I think if we go to FDA and EMA, there's been a whole shift in getting at subjective outcomes, pain, fatigue, well-being to some degree, though not so much. There's been a big shift towards going towards daily diary studies, less so towards momentary studies because they're difficult to do. But pretty much if you want to create a pain endpoint these days, you pretty much have to do at least a 7-day diary study. And the point there is that there's been a lot of work showing that end of day assessments of one's pain are pretty good at representing what actually goes on during the day versus end of week.
Excellent. Donna, final question. Do you have your button pushed on the microphone?
Donna Cryer, Global Liver Institute. What are the limitations of your methodology? So, particularly from the increased social interaction. So you're interrupting someone's daily life. You may affect what you're actually measuring, perhaps, as well as the increased burden of those interruptions in a patient's sort of work and life flow.
Yes. So 2 questions about burden and what is known as reactive arrangements or reactivity. This is, of course, a major issue in getting into a patient's life this way. There are several studies out right now that show that the reactivity is relatively low in most conditions. However, if you're doing an EMA study, a momentary study, where you're asking a person to monitor something in the midst of a clinical circumstance that they're trying to change it, then you can have some feedback that may influence them. So it depends on the setup of the study whether or not there'll be reactive arrangements. In terms of burden, you're absolutely right. There's another study that's coming up which is trying to look at how many beeps can we do, data collections can we do in a day over how many days, and how long can each of those be? And there right now is just lore about how to do that. But we're trying to determine whether or not there can be a science behind how to do that so that if you want to run a trial, you don't have to make guesses about it and that you can pretty much assure yourself that you will have high compliance.
Excellent. Thank you, Arthur. Thank you for the excellent question.